Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning. Today is Thursday, April 16th. Thank you for joining the Wild Health COVID-19 update. As of yesterday afternoon, there were a lot of cases and a lot of deaths worldwide. We're not going to go over the exact numbers, but approximately 2 million cases and 133,000 deaths worldwide. The United States continues to be the leader in both cases and deaths. In global updates, data from the Financial Times shows that the rate of increase in cases in both the United States and the United Kingdom are slowing. Signs of the outbreak may be peaking in both countries. In terms of deaths, however, the daily death toll continues to rise in both the United States and United Kingdom, although this is expected as death counts are a lagging indicator. Turkey is battling a severe outbreak with more than 65,000 confirmed cases, more than Italy had at the same stage. Japan also continues to see a steep rise in cases, but a more gradual rise in deaths. In U.S. news, the outbreak in New York continues to be appearing to slow down. In his daily briefing yesterday, Governor Cuomo reported 752 coronavirus deaths in the past day, a figure that is similar to previous days and further evidence that the death rate in the state has flattened. On Tuesday, New York City officials announced they would be changing the criteria for inclusion in the coronavirus death toll and including people who had never tested positive for the virus but were presumed to have died of it. This may include patients who died in the hospital at the start of the outbreak before testing was done, as well as patients who may have died at home or in nursing homes. This change added an additional 3,700 deaths to the count, raising the death count in New York City alone to more than 10,000. The outbreak in California has taken an entirely different trajectory than what's been seen on the East Coast. In his daily briefing yesterday, Governor Newsom explored the question of when to reopen the state and what that would look like. Epidemiologists have noted that California was poised to have a much more catastrophic outbreak due to its massive population, extensive travel history with China, and the fact that it reported some of the country's first cases. Since then, California has managed to flatten the curve and currently ranks 30th in per capita deaths in the nation.
Yeah, what's happened in California is really interesting to me, Matt. I mean, we sort of all expected California to be just a giant explosion given its proximity to China, but then it turned out that the majority of our virus came from Europe and less of it from China. So probably a good, or at least a likely reason as to why New York has blown up so much more than California. Plus California they were pretty early in their lockdown, right? If I remember correctly, they were before New York.
Yeah, a lot of mayors specifically in some of the bigger cities in California, I remember, got some flack for quote-unquote overreacting, but it definitely seems like they made a good call at this point. They've done really well there.
Certainly. Well, I've got two articles that I want to talk about today, Matt. The first one is called Population Level COVID-19 Mortality Risk for Non-Elderly Individuals Overall and for Non-Elderly Individuals Without Underlying Diseases in Pandemic Epicenters. This was pre-pub on April the 8th. The primary point that the authors were trying to identify here was to basically age stratify mortality from COVID based on a simple criteria. So you're either less than or you're greater than 65 years old. And they found a lot of things, and they reported all of these things. But the thing that I found most interesting was that there was a pretty obvious difference between the percentage of deaths that came from people less than 65 years old when you look at the United States epicenters and compare them most specifically to the European epicenters. So if we just look at a few countries here, so these are percents, this is percent of death when you're less than 65. In Germany, it's 4.9, so 4.9% of the deaths are less than 65 years old. In Italy, it was 9%. In Louisiana, 23.7%. In Michigan, 21%. In New York, 29.9%. In Spain, 4.6%. This is just consistent across the board. What we're seeing in Europe is the percentage of deaths in people less than 65 is somewhere in the range of 3 to maybe 8, maybe 9% in Italy. But in the US, it's pushing mid-20s to low 30s percentage. So we're seeing a much larger amount of deaths coming from younger people in the United States. So they don't specifically go into why this is occurring in the paper. Obviously, it wasn't powered to figure any of that stuff out. They mentioned the possibility of maybe there's a different strain, maybe there's a difference in socioeconomic class. If you go to nextstrain.org, you can actually see that there is definitively a different strain that's predominant in the United States. So the majority of our strain came initially from Europe, and then you can see this divergence between the European strain and the US strain somewhere around January 28th. There's also a little bit of strain from China in the U.S. That divergence happened back in January the 1st. That doesn't mean that this virus is more virulent. There's definitely the possibility of different socioeconomic class having, younger people in a different socioeconomic class having worse outcomes. That's certainly a possibility. That's something that's been reported a good deal in the media, is that there's a difference in mortality based on socioeconomic class. So that might be the difference between the U.S. and Europe. The study just wasn't powered to really figure that out. But I do think that it's extremely interesting that we're seeing such a difference in young people dying from COVID in the U.S. than we are in the rest of the world.
Yeah, teasing out how much of this has to do with the strain and how much of it has to do with socioeconomic factors is difficult. But I have to think. Mike, you grew up in South Carolina. I grew up in Kentucky, and for years we taught a course for physicians every year in Stockholm. And so when I look at the Sweden 4.8%, and then I look at the kind of Louisiana and the Deep South is 23%. I have to believe that a big part of that is just due to demographics. The population under 65 in Sweden is dramatically different than the population under 65 here in Kentucky where I am. And I think that is the main driver here. And I always like to look at these studies and think about the take-home points and how this is going to inform decision-making in the future. And I see a very important point to make here. And I think a lot of us are looking at Sweden specifically as, oh, this is interesting to watch this experiment, because they really haven't closed down. They've taken this approach of staying open and kind of letting this virus wash over the population and try to get to herd immunity more quickly. And while I think it's not the best strategy, I think they're going to have more difficulty than they expect. Even if it works, that absolutely does not mean it would work in the Deep South. Having it wash over the population of where I live, considering the comorbidities that exist, will be a dramatically different outcome than in Sweden.
Yeah. So if you actually look at comorbidities, the study did break it down. So New York City, only 1.8% of the deaths occurred in people less than 65 without underlying conditions. So what is notable there to me is that the majority of people who are dying under 65 years of age have comorbidities. They've got pre-existing conditions that are putting them at higher risk. And, we know that Europe has a healthier population than the U.S. If you take, pound for pound, like it's just a healthier population in terms of comorbidities, hypertension, cardiovascular disease, all the numbers. So that certainly is playing a big part.
Well, I wouldn't say pound for pound, because that's part of the problem. We've got a lot more pounds, but yeah. If you look at the New York data, about 30% of their mortality was less than 65, but only 1.8% with no comorbidities. So the amount of people under 65 with no comorbidities is vastly different in Sweden than it is in Kentucky and Louisiana. So it's going to be interesting to watch Sweden, but we cannot apply what happens to them to us. We have to look at New York. New York is a better example, or Louisiana, for states that are more demographically matched. And it's not been great for those of us under 65 in those states.
No, and we'll see more of this in the future. The epidemiology is going to become more clear, and our knowledge of the virus is going to become more clear as well. How are you feeling about hydroxychloroquine, Matt? Pretty positive
less
these
and
days?
less great. Less and less great every day.
I'm going to tell you about a case-matched observational study. So this was a French study that was pre-pub on the 15th. And this is a case-matched observational study. So it's not a randomized controlled trial, but it's better than just a standard observational study. So it's retrospective, meaning they looked back and they looked at people who got admitted to the hospital in France with COVID. They looked at one group that got hydroxychloroquine, and then they looked at another group that did not get hydroxychloroquine. And what they did is they tried to match the two groups as best they could in terms of severity and risk factors and all of those things. And they talk about how they did that in the study. And if you want to fall asleep, you're welcome to read that. The outcome for the study was whether patients got admitted to the ICU or they died in 7 days. They found that 20.2% of patients in the hydroxychloroquine group were transferred to the ICU or died, and 22.1% in the no hydroxychloroquine group were transferred. So that might sound like a 2% difference, right, Matt? But it's not necessarily a 2% difference. It didn't reach statistical significance. And what this tells me is that hydroxychloroquine is definitely not a game changer. It is certainly very similar to no treatment whatsoever. And 10% of the patients who actually got the hydroxychloroquine had potentially fatal heart rhythms. None of them actually died from their heart rhythms, but certainly prolonged QT, which is something that can happen with hydroxychloroquine, can certainly kill you. So it does not appear that the risks are going to outweigh the benefits here, at least based on the study.
Maybe. I mean, just to play devil's advocate, I did mention I'm less and less bullish on hydroxychloroquine. But again, not to sound like a broken record, but this is an observational study. You said that they tried to match these two groups, but that's simply not possible, as we know, unless it's a randomized controlled trial. So the group that got hydroxychloroquine got it for a reason. Maybe there was something these doctors saw that made them more worried and made them give them this drug, and maybe it was a more severe group. Also, I would say that 2% difference, although it's not statistically significant, maybe the study was just too small. Maybe if it did play out, that's a pretty big mortality difference if it was statistically significant. It would mean 1 in 50 people survive. You give 50 people hydroxychloroquine and you save a life. So again, this is kind of a negative study for hydroxychloroquine, but as we have said, it's observational. It doesn't actually tell us anything, and it could be read in a different way. Someone could easily quote this and say, wow, 2%, or they could make it even worse, and they talk about a relative instead of an absolute risk reduction. They could say, wow, 10% difference in mortality with hydroxychloroquine, a cheap, safe drug. So this could be read in a different way. So not to confuse people, but this is not a definitive study in any way, shape, or form.
I'd love to disagree with you right now because it's just more fun when we disagree about things, but unfortunately I totally agree with you. Obviously, this is not definitive. None of this stuff is definitive at this point. We need randomized controlled trials and we're just not getting them yet. So we're having to make decisions based on subpar information, and that's obviously what we're trying to do.
So an article that it isn't a study, but is interesting to talk about, important to talk about, is the FDA. So the FDA is now saying that they're going to crack down on antibody tests. So we've been talking about serology and how this is going to be a game changer, and we're very excited for this. So March 16th, the FDA loosened its standards and allowed companies to sell antibody tests without submitting any evidence that they worked. It's kind of desperate times, call for desperate measures kind of thing. But the FDA, although they've been working with kind of 300 test developers who say they're going to be submitting emergency use authorization requests, what's happened is the market has been somewhat flooded with bad tests. And so on April 14th, the FDA commissioner told the National Cancer Institute that the FDA is going to start reviewing tests that are on the market to see if they obtain correct results. And they're also going to kind of tighten back up a little bit. This is an issue. We have seen some antibody tests come on the market with specificities as low as 80%. And although we talk about sensitivity when it comes to detecting virus and if someone's contagious, because we want to rule that out, with the antibody test, we want to rule in. So we worry about specificity. So what that means is if we test someone with an antibody test, if it's a positive test, we want to be sure it's positive and not a false positive. Because if you test 100 people who come back positive for IgG antibodies and you give all of them the thumbs up that you are immune and you're not going to catch this, and the specificity is 80%, that means 20 of them are not. So those people are going to go out having a false sense of security and may actually catch the disease. So that's a big problem. So we need specificities in the kind of 95 to 100% range. And because of this kind of loosening of restrictions, there were some bad tests. I think there were some other issues with faulty tests as well, but the specificity part, I think, is the big one that we have to worry about. So, I mean, and again, this is important because I literally got a call yesterday from someone that said, hey, I've got a contact in Switzerland that has 300,000 antibody tests. And they were excited about this, and because there's an issue of access to testing, but it doesn't matter how many tests we have if they're bad tests. So if in the general population, if you start seeing people offer antibody tests, you got to, as a consumer, think about and at least ask the question, what is the specificity? What is the sensitivity as well? That's important, but not as important as the specificity with antibody tests. That is going to be a very important question as we move forward, especially into the kind of return to work and return to play. We know that identifying those people that are immune and have the circulating antibodies, that we assume to be immune. There's still some question about immunity and how long it lasts. There's lots of questions around that, but that is going to be an important component. So just as a reminder, we are having a Zoom webinar on April 22nd, talking specifically about return to play and return to work. We're working with quite a few large organizations, sporting leagues, and other businesses on this question. And it's not time to go back to work. It's not time to go back to play. But when it is time, we need to have a plan. And those organizations and groups need to understand the operating characteristics of the test. They need to understand logistics, security, what the risk actually is, and get that risk down to an acceptable level to the public, to the attendees, and to everyone involved. So if you want to be a part of that discussion, go to wildhealth.com and you can register for that Zoom webinar. It's completely free, but you have to register so that you can ask questions and join in on the conversation, because we want to have a robust conversation, not just a lecture to you. So go register there. And tomorrow we will be releasing another podcast, again, every day, and every other day is going to be an update like this one. Thanks for listening.
Stay safe. Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.